Okay, and we can go ahead and get started. Thank you for joining us. Welcome, everybody. My name is Joanna Smith. I'm a behavioral health consultant in the Southeast Michigan region for the Michigan Opioid Collaborative. This is the first session of our MOC MC3 Perinatal mini-series, and today we will have a presentation from Nancy Wren-Begay on trauma-informed care for pregnant and perinatal patients. And I'll have her introduce herself in just a moment, but before we get started, I wanted to just make another announcement to please sign into the chat with your name, your email address, and your organization name for our attendance purposes. This session is being recorded today, and it will be posted on our website at a later date. But we will not be offering CEUs or any credits for this, but we do have other webinars on our website that do offer credits, so feel free to check out our website, please, if that's something that you're interested in. Please also make sure that you're muted during the presentation. If you do have any questions, we will be saving some time at the end for Q&A, so feel free to post them into the chat, or at the end we will address those questions. After today's session, your regional behavioral health consultant will be emailing you afterwards with the slides and any material that we discussed today. So before we get started, I wanted to briefly introduce the rest of our team here, starting with Megan.
Good afternoon, everyone. My name is Megan Collette. I'm the behavioral health consultant with the Michigan Opioid Collaborative for the Western region.
Thanks, Megan. And Katrina, do you want to go next?
Sure. Hi, I'm Katrina Hernandez, and I am the behavioral health consultant for the Michigan Opioid Collaborative, and I cover the Central region.
Thanks, Katrina. Angie, do you want to introduce yourself?
Sure. Hi, everyone. I'm Angie DeSantis, and I'm a project coordinator with MOC.
And then Nancy, do you want to introduce yourself real quick?
Sure. My name is Nancy Wren-Begay. I'm a certified nurse midwife, and I work at in the Great Moms program at Corewell Health West now.
Thank you, Nancy. And Melissa.
Good afternoon, everyone. I'm Melissa DeMars, and I'm the Upper Peninsula Behavioral Health Consultant with the Michigan Opioid Collaborative.
Thank you. And before we go ahead and get started, we're going to give a brief introduction to, or a brief overview of what the Michigan Opioid Collaborative provides.
Thanks, Joanna. So the Michigan Opioid Collaborative is a grant-funded program aimed to increase the availability of medications for opioid use disorder and addiction treatment in Michigan, as well as bring awareness and education to all substance use disorders. The MOC offers free same-day consultation services to providers for any patients with substance use disorder. We offer quarterly introduction to buprenorphine trainings, as well as webinars on a variety of educational topics such as addiction, healthcare, and substance use topics. We provide support for diagnosis, treatment planning, and medication management. We have a hepatologist on our team who offers hepatitis C treatment consultation within 48 hours. She also facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on hepatitis C treatment, which is available on our website. We've also created toolkits for providers to have more resources when treating patients with multiple substance use disorders. I'll hand it back to you, Joanna.
Thanks so much, Melissa. So let's go ahead and get started. I'm going to hand it over to Nancy to go ahead and talk about trauma-informed care.
Okay, well, this is a subject that is very intense, and I want to just warn anybody, if anything triggers them in this talk, that they can always jump off this webinar if they need to. Also, I'm a nurse midwife. I've been a nurse midwife for 23 years. I worked at the Salvation Army, and I worked with pregnant patients that were teens, and there was a lot of trauma with my patients. And I really work to create a relationship with them. And as you'll see as I go on, that's one of the most important things that we can do for our patients to help them not become re-traumatized. The subject is probably covered over, well, I went to a 2-day trauma conference, and so there's a lot of information here, so I'm going to try to get through it pretty quickly. What I'm going to quickly go through is what is the definition of trauma, and what it does to us in our bodies physiologically and psychologically, and then how do we work with our patients knowing this information? So on the first slide here, you can see that this is one of my favorite examples of trauma, is any type of distressing event or experience that can have an impact on a person's ability to cope or function. Trauma is a result of emotional, physical, or psychological harm. It can be a single event. It can be multiple events. It can be prolonged over a time. That's the most damaging. And it's the most damaging trauma that can happen is at the hands of someone that is trusted, such as an authority, a trusted figure. And so that seems to be the worst trauma, and the more intense the person is influenced by that trauma. Okay, next slide. So here's some traumatic events, just even lack of emotional support. If you are in a situation where you're homeless and you don't have the things that you need in life, such as food and protection. If there's divorce in the home, if there's a lot of discourse in the home, if there's alcoholism and drug use in the home, which for the Great Moms patients, a lot of my patients had that in their homes. And it's what led them to start using and end up with a substance use disorder. Mental illness, attempted suicide among members. So if your mom, your dad, your brother, your sister was successful at committing suicide. And then also if you have parents that are in and out of jail. And if you score high on these issues, you're more likely to be involved in prostitution, have mental health disorders, substance use, and early criminal behavior. And then also, this is not just about SUD as far as what trauma does, it's also about physically what it can do to you. So next slide. So adverse childhood events. I'm not sure if everyone has heard about the adverse childhood events, but this was a study that was done back in 1995 by Vincent Folletti. And what he did is he went to he was a preventative medicine physician. And so he worked in Kaiser Permanente in San Diego. And he noticed that when he worked in a lot of obesity stuff, and he noticed when he was talking to his patients about obesity, he noticed that the patients always talked about trauma in their lives and how food was how they filled that trauma. And so he did a lecture, and he said, maybe trauma is causing more problems than we think it is. And he met up with Robert Anda from the CDC, and the two of them came together, and they started to do a lot of studies on trauma in the life of a person and how that influences their mental and their physical well-being. So next question, or next slide. So I thought I should really put the questions down here if someone is not aware of this. And this is a good screening tool. In fact, I think in California, in primary health, it's like a mandatory screening tool for all their patients. And you can see some of these questions that I went over. They ask these 10 questions, and then depending on how many you get right, that sort of increases your risk of having other issues. Next slide. So what they found when they studied it is that really 87% of us have had 2 or more ACEs, and that would probably be easy because if you live in a divorced home where there was a lot of yelling and screaming, you got 2 ACEs. So, but 12% had 4 ACEs, and anybody that had more than 4 ACEs tended to have a lot more issues in their life. Next slide. So these are some of the study results that they came up with. you know, of the issues that people had reported in their lives as far as trauma. And you can see there's a lot of like physical abuse is very high, 30% were exposed to that. So, okay, next slide. So this is just a little schematic. There's even more schematics that you can find, but this is more, I think, focused on SUD, because if you had 4 or more ACEs, and they did only study people that had 4 or more ACEs, they didn't go up to 6 or 8, they just stopped at 4 and said, if you had 4 or more ACEs, you know, we know that there's going to be issues in your life. And you can see that if someone has 4 or more ACEs, there's 11 times more likelihood that they're going to use intravenous drugs. And so, which brings us down to, you know, that's the population of people that, you know, I deal with, and I'm sure a lot of other people work with. So that's why this is so important. Okay, next slide. So the reason this is so important to me is because you know, 1 in 3 women report a history of physical abuse or sexual abuse, and 78% of those were under 25 years old. And who are the women that are getting pregnant? You know, probably under 25 years old, and even under 40 years old. I mean, under 40% were under 18 years old. So that's why that's important to me. So if they're more likely to use intravenous drugs, and you know they had this traumatic event, these are the kind of patients that we're going to be seeing. And one of the important things is we want to make sure that we don't re-traumatize those patients. Next slide. So what does trauma do to us? Well, it interferes with our neurobiologic development and basically the capacity to integrate sensory and emotional and cognitive information. And so this is really important when we're working with our patients, because you have to understand that this is what's going on in their life. And then it's our job as healthcare providers to try to work with them to make this better. So, and why does this happen? Next slide. So I can't go through this whole thing, but basically when we're under stress, stress is a good thing. So if we're if we're on vacation and we're in a foreign land and we're walking down the path and we run into a lion, it's going to be really important that our bodies realize that this is a danger, and we need to either get away from this danger or do something to make it, make it better. So our body goes through and it stimulates the HPA axis. And you can see that here. So, you know, our heart rate increases, our blood pressure increases, and then, you know, we get all the blood flowing to our muscles so we can run like heck. So, but the problem is if it's prolonged, that's where things start getting a little bit crazy and it doesn't work as well. So this is what causes all the disease states with prolonged trauma. Next slide. So I thought this was an interesting picture of what happens between safe and unsafe. I think if everyone knows in substance use disorders, our patients have a hard time using their prefrontal cortex when they have addiction issues. And so that's the same as in trauma. If a person is, subjected to chronic trauma, they're going to go to a more primal area of their brain, and they're not going to, their prefrontal cortex is not going to work for them. So when they are upset and yelling and having a hard time, it's not because, it's really any fault of their own. It's their brain has changed and they go to a more primal area of their brain to deal with what's going on. So next slide. So the reason this was important to me is Dr. Folletti found that more than 50% of women with depression had more than 5 ACEs. Oops, I said more than 5 SSs, but it's ACEs. And changes in the brain from childhood trauma can be related to SUDs. And like I said, a lot of the women I care for have had a lot of trauma in their lives. And then trauma affects the nucleus accumbens, and that's a pleasure center of the brain. And this is also something that is affected in trauma. And so like I said, if someone has had a lot of trauma in their life, they're more likely to reach out and try to, sort of kill those feelings that they're having. And a lot of times they reach out, we all know people reach out for food, people reach out for gambling, people reach out for other things. And it's to sort of help to soothe those traumatic feelings within their, mind. So that's why we end up having these issues. Right. So I sort of like this picture because, someone who has been involved with a lot of trauma, especially chronic trauma. So if they're always being yelled at, or they're always being beaten, or they, don't have food, or they don't have a place to live, they get really frustrated really quickly, and they go back to that primal area, and they're not going to be able to use that prefrontal cortex. And I'm sure everybody in this audience has seen before, or has experienced before, being that lion. I know I have. I had a couple situations a few days ago, and I was very frustrated and sort of lashed out at someone, and it really wasn't their fault, but it was just things were not going right. So all of a sudden my brain said, okay, it's time to survive. And so I'm going to get a little bit upset with someone. So that's what happens to our patients. They go back down to that primal area, and they may lash out, but it's what they do to survive on a daily basis. Okay, next slide. So I think you've seen some of these things in your life that responses to trauma, and it depends on whether it's chronic trauma or just an acute trauma, is most likely you're going to fight if you're in that situation, or you're going to run away. But there's times that we have to freeze, and our body tells us don't move. But the one that really concerns me as the most is surrender. As far as obstetrical patients, I have seen that a lot with chronic sexual abuse with my patients. And one of my warning signs of a patient who is in labor and delivery, and we're going to do a vaginal exam and check her and see what's going on, or we're going to do some other kind of procedure where it's going to be involved in her genital area, is I always worry about someone who really gets upset and starts fighting against you, or just surrenders and looks the other way. You'll see them sort of stare out into a corner someplace. And that's because during their abuse, that's what they had to do to escape. They had to, they weren't able to fight. Maybe they were a young child and they were being abused by a family member. And what they would do to escape is they would look at a drape, or they would look at a picture on the wall, and they would try to, they would just surrender to what was happening with them because they knew they couldn't fight. So we have to be really careful in how we care for our obstetrical patients and our SUD patients, especially in like the Great Moms program. If I'm going to do a pap smear, and I always explain why I'm doing it and how I'm doing it and what's going to go on. And if there's any resistance to it, I'll stop and I'll just say, you know what, we'll do this another time. And sometimes I wait till 3 or 4 appointments before I even do their physical. Because once again, as I will go through, is they have to develop that trust with you. So these are the responses sometimes you'll see in your patients. Okay, next slide. So I just had this little story about Brittany, which, sort of has happened with us a lot. So I'm going to tell you the story. She's 25 years old and she's pregnant for a second time. Her boyfriend left her right in the middle of her pregnancy, and now she's all alone. Her family history reveals that both of her parents were alcoholics. Her father was abusive to her mother. So we're just stacking up those aces right now for Brittany. And she wanted to go to college, but she couldn't go to college because she got pregnant, when she was 17 years old. And so that was off the table. She's living with a friend. She doesn't have a car. And really, she's sort of stuck in this situation where life isn't what she thought it would be. She has an appointment at your office, and, she may live 5 miles away. She may live, 2 miles away, but she doesn't have a car. So she has to in order to get to your appointment, she has to get on a bus and she has to come to your office. And she has a little bit of an issue doing that. So she arrives 10 minutes or 20 minutes late. And the front desk is told that if anybody is 10 minutes late, then their appointment is canceled. So she sees this as a lion. So she will lash out. She will probably start yelling and screaming and saying, I don't know, I tried to get in here, I couldn't get here. So this is like re-traumatizing her. So you want to do some of the steps that we'll review in trauma-informed care to make sure that the situation does not happen. So next slide. So what is the definition of trauma-informed care? What I like to say is it's just be nice, be kind. And we want to make sure that everyone knows that more than likely, everyone you run into has had some trauma in their life. It might have been just one experience that they had, but there's a lot of patients that you take care of that have had chronic trauma in their life. And especially if you're dealing with SUD patients and perinatal patients, that's what's probably going to be the case. So we want to make sure that we know that trauma plays a role in her life, and we need to learn how to work with this patient and to make her experience a little bit better. Okay. So basically, this is trauma-informed care. It's a good description. It's strength-based, that's grounded in understanding and responsiveness to the impact of trauma, that emphasizes physical, psychological, and emotional safety for both providers and survivors to rebuild the sense of control and empowerment. And a lot of the trauma-informed care is you give the power back to the patient. You have to realize that, especially if you're a professional, and especially if you're, some type of a provider, you're an educated person, you're in a position of power, and you want to make sure that you share the power with that patient, and you give that power back to the patient, and it becomes sort of an agreement and a working between the two of you to make sure that you're not going to re-traumatize that patient. So they suggest that organizations be trained on this trauma-informed care, and that we understand the triggers of trauma survivors, and that the way we traditionally deliver services may cause re-traumatization of the patients. And so then we want to make sure that our programs are more trauma-informed. So next slide. So the traditional approach to trauma is more that you're sick, you're bad, why are you doing this? What's wrong with you? And what we're trying to get people to understand is that what you need to do is approach your patients as, they're not sick or bad. They've been through a hard time. They might have had chronic trauma in their life. It could have been that they missed that bus or whatever, and that someone did something to you, and we're not going to do anything to you to make this worse in your life. Next slide. So the core principles of trauma-informed care is awareness. You know that everyone has been involved in trauma. Safety, that's a really big one. You want to make sure that your patients are safe, ensuring physical safety and emotional safety. Sometimes that means having someone in the room with you, that means, like I said, sometimes you're not doing physical exams on that first appointment, especially for healthcare providers. You want to take that time to make sure emotionally that they're safe. Trustworthiness, that's a really big one, and that takes a long time. And I'm sure the social workers out there know that, it takes a long time to talk to someone and hear their story and get to that place where or they know they can trust you, and then make sure you're maintaining those appropriate boundaries. Choice, respect, and prioritize consumer choice and control. This is a big one for me. I worked labor and delivery for a long time, and it's probably because I'm a midwife, but I always respected people's choice and what they wanted to do. If they didn't want their water broke, then that's fine. I always, talk to them about sort of the next one, collaboration. Like, this is why we need to do this. We can't hear your baby's heartbeat. We're really afraid your baby's not going to be well if we don't put something on the top of the baby's head, and that's going to be involved in an exam. And is that okay with you? And these are the reasons that we're doing this. And so you empower those patients to say, yes, well, this is what I need. This is what I want. And then one of the things you have to do is make sure that trustworthiness, the safety, the collaboration with the patient is there. And once you have all those things together, the outcome will probably be better for everybody involved. Next slide. So how do we provide trauma-informed care? Sort of you're probably understanding from what I've been saying so far. You want to just sit and listen. Which is really hard for me. It's really hard for me to just sit and listen. But you want to really sit back and listen to what the survivor is saying to you, what your patient is saying to you, because we're assuming that everyone has had trauma, and especially if you see some type of a reaction that is not quite within the norm, your brain should be going to, what just happened to this patient? There's something going on. So you want to talk to them. You want to listen to them. You sort of want to come up with an idea of what is the survivor not saying, because not everybody wants to come out and tell you their whole story. But can you listen and come up with some idea of what that person is saying to you? And how are they saying it? Are they screaming at the top of their lungs? Are they just shutting down and only saying 2 words to you? What is going on with that patient? So listen, inform. What information do you have that may help her? So this is more like help her understand what's going on, help her understand her care. What is, like I said, that's all about collaboration and listening to the person. And, what's going to happen next in the process. You want to be real clear that this is what's happening and what she can expect. And then what can she change? What is that, what can your patient change about what you have explained to her? And, why is information important for her to have? And how can your services help her? Next slide. So these are some of the ways that we can provide trauma-informed care too. I have another. The next slide is on labels, but lose labels. Try to talk to people respectfully, and understand that they are people just like you and I. Maybe they've gone through more than you and I have gone through, and labeling them in a derogatory way is not going to help anything. Let them tell your story. Like I said, listen, let the survivor lead, respect their voice and what they say. Sometimes, patients in my past have said things that they're willing to do or not willing to do, and you have to respect what they have to say. I'm a big one on, I explain to you why this needs to be done, what's the evidence that it needs to be done. And then, let's just talk about COVID vaccines. We won't get into it, but just that's, pretty controversial. And so I just explained to them, during pregnancy, it's recommended by the CDC and ACOG that you get a vaccine. And if they say, no, I'm not getting a vaccine, I explained to them, well, it'll go to your baby. But, I say, this is totally up to you. It's your body. So you make your decision, go home, read up on it. If you change your mind, let me know. But if they're saying no, no means no. As I always tell my grandkids, no means no. And then recognize the survivor's comfort level. You're probably not going to have that right away because we talked about trust. So me walking into a room and that patient has no idea who I am or how I relate to this, her life. And so we want to make sure that you just continue to build that relationship. And if they're not comfortable with you, you just sit back and try to take the time to build that comfort. And then once again, we always have to listen to the person's perspective from their cultural context, their family context, and what is important to them. So you have to do that if you're going to practice the trauma-informed care. Okay, next slide. So here's some of the languages and words that we can use that are derogatory, and we're trying to get everyone. And I think we're making some really good progress in this and letting everyone, describing people as a person with a substance use disorder. A person with a diabetes, not a diabetic, not an addict, not a drunk or an alcoholic. It is a person that has this condition, and so that's how we refer to them. And I have to correct Dr. Poland, and I have to correct people all the time in our office when they say, "Well, I've never had a dirty," I haven't had a dirty screen in 3 days, or I don't have a dirty screen today. We try to say, well, no, it's sort of we like to phrase it as there were expected results or unexpected results. Because if you say dirty, that means you're dirty, and you're not dirty. You're a good person. You have a substance use disorder, and this is how we test to make sure everything is okay. So you had positive result. You had expected results, or there was an unexpected result in your urine at this time. So those kind of changes in language are really important. Okay, next slide. So this might be just, pounding it into you, but trauma-informed care, these are the core competencies that you want to try to work your staff to have. And I don't think there's a whole lot of, institutions that mandate trauma-informed care, which I really think everybody should be mandated to have that. But you want to make sure that they have that understanding of what does trauma do to a patient's brain. And you want to shift away from shame and blame to a more compassionate understanding of what's going on, what is happening with them right now. Once again, you want to focus on those interpersonal interactions, and you want to create trust and respect between you. She has to know that when the patient shows up to that front desk, right from the front desk, who's bringing her in and checking her in, has respect for her as a person and understands that that's how she should be treated. And you want to create a safe environment and a nurturing environment. So, when a patient shows up to our front desk now and she's late, we just say, just wait a minute. We'll get someone out to talk to you. We'll see, you missed your ultrasound or whatever. And we'll see, maybe we can fit you in. Let's just take this one step at a time. I'm sure you had a really hard day. I'm sure I really appreciate all the effort that you made to make it to your appointment. And I'm so sorry that you missed your ultrasound, but we will do everything in our power to try to make sure that happens for you. So, work with them, create a create a nurturing environment. So you're not re-traumatizing them and just, you know, basically being really mean. That's what I say. Okay, the next slide. So, like I said, you want to make sure your staff understands they need to learn to listen to others. They need to self-reflect on, you know, their attitudes and what's going on with them. Many of our staff members have been through trauma. So, you know, if you have someone that has been through a lot of trauma, that is now going to work with another person that's been through a lot of trauma, there's a lot of work that needs to be done between those two people. So do a little self-reflection on them and their attitudes. I know at the Great Moms program, when we started out 5 years ago, there were different kind of comments like, you know, why is she doing drugs? Why doesn't she just stop that? I don't understand. She's pregnant. And I hear that from everyone, even friends of mine. And, you know, why don't they just stop using heroin? Don't they know they have a baby in their, you know, stomach and that's growing and they're, you know, giving heroin to their babies? And so we had to really, you know, educate them on what these patients have been through and that they need to look at themselves and look at their attitudes, and we need to change their attitudes. And then understanding the historical trauma associated with race, culture, gender, that's becoming really important now, and I'm glad that's in the forefront. So we need to understand all that. And then we need to know how to self-manage our emotions. If it doesn't do well with a patient if you're not trying to re-traumatize them. If you are the person that now is yelling at them and they're yelling at you, you need to take control of your emotions, and you need to learn how to work with people and the words that will help them trust you and work with you and decrease that heightened sense of danger that they feel at the time. And then once again, we all have been told we need to take care of ourselves, because if we're running every second of the day and we're not taking care of ourselves and we're not eating or sleeping or that type of thing, we're not going to be able to take care of our patients. So next slide. So what is the association between trauma, pregnancy, and SUD? Well, there is a strong link, because we know that with trauma, there's brain changes. We know with SUD, there's brain changes. We know that the frontal cortex does not function as well if someone is in the middle of addiction. And we know the frontal cortex doesn't work well if someone's being re-traumatized. We know that there's an increased chance that a patient that is has an SUD has had some trauma in their life. Like I tell my patients or the nurses that have questioned me, or my friends, you know, they're like, why are they doing this? And I just say to them, what was your life like? Just tell me a little bit about your life. Did your mother start asking you to use heroin at 14? You know, were you locked in a closet at night and you weren't given food to eat? Is that something that you experienced in your life? And of course I say no. And I say, then you have no right to judge what's going on with this person. And as a healthcare provider, it's your job to work with this person and understand that's what my patients have been through. We know that trauma and SUD are, like I said, limited part of the frontal cortex. Re-traumatizing with someone that has an SUD can lead them to relapse. That's what their brain tells them to do. They, you know, that's their comfort zone, and they go back to that. And once again, like I said, their prefrontal cortex is not working. And so if they get in a situation where they're re-traumatized, their go-to is to start using again, you know, start eating again, start gambling again. You know, it's where their comfort zone is and where they feel safe. Like I said, it impacts both of those impact the brain. So you need to know what part of the brain is this person functioning in right now, and are they feeling safe? Are you helping them to feel safe? And so those are the important questions that you need to ask yourself. Okay, next slide. So these are sort of the go-to, ask what happened to you instead of what's wrong with you. Try to understand that past trauma can be triggered by experiences in the present. Be committed to supporting people as they heal. Leave a person feeling educated as to why they may feel or react the way they do. I talk to my patients all the time. We don't do the ACEs study, which I would sort of like to do, just to give a little bit of an, idea of how many ACEs they have, but I do feel like they would be over the four ACEs. But I tell them, they're like, I did it again. I used again, and I just say, back up. Let's not blame you. Let's blame what's happened to you. So let's just go forward. You can't look in the rearview mirror. You just have to look forward. So from this point on, that's where we're looking. We're going forward. And give them tools to cope. And then once again, counseling is really important, because we do not have enough social workers in America right now. We need social workers in every office and in every school. And so we need to have someone there to offer them those tools to help cope. Next slide. So I found this, what is it called? World Google or whatever it's called. I don't know what it's called. But basically, I say this is just sort of the easy way to tell you how to deal with people that have gone through trauma. Be nice to them, be sympathetic with them, be a little tolerant with them, so all these different things are what you need to offer to people with trauma. And that's why we need to offer this to each other too, because all of us have gone through some type of a trauma before. So, when you're in a situation where you're hearing someone yell and scream, just remember, be nice to them, try to figure out what's going on, take a check of your own life and where you're at, and try to meet that person and work with them, and you'll both come out feeling a lot better. So. And so next slide, these are two books that I really suggest that anybody that's interested in trauma read. Childhood Disrupted to me is like the best book I've ever read. My family has a lot of trauma, past trauma. And, this was an excellent book, and it's by this Donna Jackson. I can't pronounce her last name, but she also does a YouTube video and on ACEs, and it's excellent. It's a TED Talk. So this specific person does that. And then Bessel van der Kolk, that's the trauma, the person I went to his lecture and learned about trauma. And this is a very long book. It's like 700 pages. It's intense reading, but really he's sort of the guru of trauma. And so that's another good book to read if you're interested in. And then I think it's just my resources that I went through. So I put a lot of, things that you can click on and go to and all that kind of good stuff. And I think that's it.
Thank you so much, Nancy. There's a lot of really great information. I did just want to remind people that these slides are going to be sent out to you afterwards. And I also wanted to bring attention to the fact that we're joined today by Dr. Kara Poland as well as Kaylee Fisher. They're also part of the Great Moms Project with Nancy. Did Kaylee or Kara, did you want to introduce yourselves today?
Sure, I'll go. I'm Kaylee Fisher. I work with Nancy and Dr. Poland with Great Moms. So if you guys have any questions or want to get connected, you can always contact me and I'll help bridge you guys together. Thanks.
And Kara, if you're still on, did you want to introduce yourself?
I'm Kara Poland. I have the privilege of working with Nancy in clinic and partnering with the MOC team on the Great Moms program.
Thank you so much. So now I wanted to open it up and ask if there were any questions for Nancy or Dr. Poland about anything that we talked about today. I know that,
Wonder, oh,
sorry, go ahead, Barb.
no, I started thinking about, is there things we can do? So we recognize and we treat our patients in this way, but is there any way to help them in that recovery from the trauma they experienced? Do you have any therapies that you recommend or things that may help them manage that trauma when triggered, or again, if not receiving that good care?
Yeah, that's probably more addressed through one of the social workers, because I've read on trauma. I went to Bessel van der Kolk, conference for the day. But I think maybe the social workers or psychologists, if someone has a lot of trauma in their life, and you think they need to be referred for counseling, I think that's the best situation. Kara, do you know of any, or have you any thoughts?
I see some folks putting things into the chat as well. So definitely reaching out to local counseling and therapy resources that have a trauma-informed lens as part of their system of care is important. And like, honestly, I want to be treated with through a trauma-informed care lens. Like, it just seems like it makes sense, because we can't look at somebody and know what their background is, know if they've experienced trauma. And so it just, to me, is almost a compassionate care model that everyone would benefit from. And certainly when we're talking about prenatal care, we are doing some invasive exams on folks that we want to make sure that they feel safe in that environment. And just a plug for MOC services, if you are looking for collaboration with behavioral health services in your community, we can also assist with making those connections. Joanna, I don't know if you have any other details you want to share about that process.
Well, you know what, all of a sudden as you're talking, Dr. Poland, that EMDR, that's a training you went through. And I think I did not go through that. I'm a nurse midwife. And so I'm leaving that up to the counselors, but I think that is really focused on trauma.
Karen, your comment Karen Gall put a comment in the chat that is very appropriate. Lots of concern about re-traumatizing patients that seem to have folks hesitant to broach the subject of traumatizing experiences. Anything specific beyond ensuring the patient feels they are in control of the situation to prevent re-traumatizing. Letting the patient sort of lead the conversation is very helpful. Making sure that making sure that you've established that rapport before you kind of delve deep into it. I always tell people I have this nice long patient intake history and physical, and sometimes I do like a quarter of it because sometimes we need to, as Nancy mentioned, establish that relationship and rapport before we can ask the questions that are more personal or going deeper into their past use. And as Nancy also mentioned, reaching out to counseling, therapy, and experts in that area if that's not your area. It certainly isn't mine. I clearly am trying to learn more by taking some additional training as a physician, but it would be we just recommend that we let the patient sort of lead those conversations, unless of course there is safety risk there. Sometimes we do have to ask hard questions to keep our patients safe, and sometimes that may involve their children, their significant other. I've certainly called the police to do safety checks on people that I'm very concerned about. So please, safety first. But Dr. Music, I think I saw your hand raised.
Thank you so much, Kara. I just wanted to say that in general, when you think about someone who is traumatized, and Nancy, you outlined it so well, the primary focus initially needs to be to calm your nervous system, right? There are two levels. The first is to calming the nervous system and help you every time you get triggered, and everything could be triggering, and you never know. It could be just kind of a visual cue, a smell, using the words, going back in the memory. All of this is triggering and will raise the sympathetic nervous system, the amygdala, the fear circuits. So any trauma treatment, the first piece is emotion regulation and calming. And therefore, all treatments for someone who is really kind of in this hypervigilant state, all treatments that provide calming to the nervous system are helpful. That can be from mindfulness, acceptance and commitment therapy, DBT, emotion regulation therapies, just kind of sitting with deep breathing, meditation, jogging, anything that calms and regulates your body. And even those then so-called trauma-informed therapies like trauma-informed CBT or EMDR or processing therapy, where you start going into the trauma narrative and rewriting the narrative of your trauma. I mean, that's the thing. You cannot undo the past, but you can help your body come to peace with what happened and come out of it healed by virtue of saying, you know, it wasn't my fault. There's no reason for me to be ashamed, because that's one of, as Nancy outlined, trauma causes a change of your worldview. It was my fault. I'm dirty. I'm ashamed, and nobody is to be trusted. My safety is gone, and I am a bad person. And you have to kind of downplay this with substances or whatever you do. But in order to be able to rewrite this narrative, you have to be able to go to the narrative. And that's why every trauma therapy, the first year, you're spending learning strategies to calm your brain. Even EMDR, or whatever you do, I did an EMDR training. The first half year, depending how strong this is, your trauma hypervigilance is, you have to learn to self-regulate. Basically, you know, step on the brake. Otherwise, you push someone, and that's what Karen was saying. If you don't know what you're doing and you go right into the trauma, talking about the trauma, you might trigger and get someone re-traumatized, and then they might have to, they're so overwhelmed that they have to, you know, cope with the flooding by using again, or gambling, or whatever they do to kind of self-regulate. Mm-hmm. And so that's really important. So you don't have to send anyone to a specific trauma therapist if you don't have anyone in your region, but someone who is understanding that to calm the brain, that's the first step. So that's all what I kind of think is really important.
Thank you, Maria.
Thanks, Dr. Mizik. There is a question in the chat. In a scenario where a patient is dissociating or having a trauma response, how would you recommend handling it in the moment?
Well, I was going to say, as we were talking, I was thinking of Betty Zylstra, who was my supervisor at the Salvation Army, and she was the best at meeting people that were having a hard time, because we had we gave food out to people as a food bank, and when they would come in and they couldn't have food for some reason, or they were upset, she approached them very calmly, and she kept her voice very low, and she sort of started reflecting about their feelings. You know, this seems really hard to you. I'm really sorry you're going through this. You know, what can we do for you? Let's between the two of us, let's do that. So I always thought, I mean, if someone, I mean, we had, big guys, that were very upset with things, and she would somehow just calmly get them back in the right frame and get them, understanding, listening to them, offering them help. So that always worked as far as I could see. If someone else has a suggestion, that'd be great.
I did see that Alva had her hand up. Alva, go ahead.
Yes, my question is, how do you, or do you know of any ways to, or is there any practices that you put into your life to deal with the guilt of not being able to help certain situations? I know that sometimes as workers that work with people on a daily basis, we try to solve, sometimes I find myself trying to solve all of their problems, and obviously sometimes that's just not possible. And there's a certain guilt that comes along with that, of not being able to fix everything for them or solve all their traumas and put them in a good position in life. So what would you say are some things that you do, or like any trainings or anything to be able to deal with that guilt?
I think I was like that long ago. Now I'm old. So it's, yeah, I don't know if there's any trainings, but you have to look at yourself and say, you are not the savior of everyone. And you do your best job. You work with that patient. You do everything in your power to help that patient. But you're not going to save people if people have been through chronic trauma their whole entire life. And you just do your best and say, I did my best. But if anybody has any training or ideas for that, that'd be great.
We just strive to, and I think Maria at her clinic as well, and I'm sure many other folks that I know and don't know on this webinar feel the same way, but we strive to create the safest, most person-centered care environment that we can for our patients. So we also spend a lot of time telling our patients that if I'm not the right personality for them, they don't have to see me. If Nancy's not the right personality for them, they don't have to see them. They don't have to see her. And our goal is to make sure that they get the best care that fits for them and their situation. And we try to make it as sort of non-healthcare centric as we can, and make it as patient centric as we can by being purposeful in terms of the secondary trauma that we receive as healthcare providers. We also have a social worker who provides therapy in our office, and the three of us do a lot of debriefing internally within our team on some of these situations that can be difficult for us. Either I think we know each other's backgrounds pretty well, so we can also identify each other's potential for triggers in our patient cases. Part of why I started doing women's health based work as a general internist many years ago is because my brother died of a self-inflicted gunshot wound related to an alcohol use disorder. And I found when I was trying to treat kind of that 20 to 30-year-old male age group, I wanted to save them. And it was not a healthy environment for me. So also identifying what are healthy environments for you as a provider, what are less healthy environments, and finding colleagues and teams to work on where you can be open and honest about how it is impacting and affecting you, and being able to talk that through with, in safe spaces. I feel pretty strongly that everybody can benefit from a tune-up with a therapist throughout at different stages in our lives. So if you're at, if something does really impact you, it is a sign of strength, not a sign of weakness, to reach out to appropriate supports.
So I did want to thank you all so much. We are coming up on time. It's about 12:59 right now, so I want to be conscious of everybody's time here. But thank you so much, Nancy, for sharing your presentation, and Dr. Poland and Maria for sharing their information around this topic. Your regional behavioral health consultant will be reaching out to you to share the slides, and we definitely encourage you to reach out if you have any further questions. We're happy to get you in touch with Nancy and Dr. Poland if you have any further questions about this topic or about the Great Moms program. So please keep an eye out for an email from us, and let us know if you have any questions or would like to connect further. And thank you so much for joining us today. We really appreciate it. We will also, I will add that we will be having 3 more sessions related to our perinatal mini series, and your behavioral health consultant will be sharing information on how to sign up for those upcoming 3 sessions. So thank you again.